Hello, everyone. Welcome back to PodBites, where we break down complex medical topics into bite-sized pieces, perfect for your commute, coffee break, or whenever curiosity calls. I'm Mariam, your host for today's episode, and joining me is Aylin.
Hey everyone!
Today's topic is eating disorders.
Before we even talk about anorexia or bulimia, we need to understand something fundamental. Eating is mainly about survival, but there's some reward aspect to it as well.
Biologically speaking, eating is one of the brain's most powerful reward behaviors.
When you eat, your brain activates the reward circuit. Specifically, dopamine is released from the ventral tegmental area, or VTA, and travels to the nucleus accumbens, which is part of the ventral striatum. This dopamine release creates pleasure, motivation, and reinforcement. It's the same pathway activated by addictive drugs.
So, food, dopamine, and reward are tightly linked. Eating literally makes your brain feel good. It's like an addiction.
Yes, and in eating disorders, this reward system becomes dysfunctional. Instead of producing pleasure, food may produce anxiety, fear, or loss of control.
So, Eileen, where does self control happen normally?
Self control is the job of the prefrontal cortex. The prefrontal cortex is responsible for impulse control, planning, and decision making. It helps regulate emotional and reward driven behavior. But if someone is under stress, the body releases cortisol, and cortisol weakens the prefrontal cortex. When the prefrontal cortex is weakened during stress, the limbic system, which is our emotional brain, starts to take over. This leads to impulsive or compulsive behaviors like binge eating or extreme restriction.
So, what you're telling me is a strong, healthy prefrontal cortex means good control, while during stress, there is a weak prefrontal cortex, and the limbic system takes over, leading to more impulsive behavior. So, some people are at a higher risk of getting eating disorders. Can you tell us what makes you more likely to develop an eating disorder?
Of course, risk factors include perfectionism, low self esteem, family conflict, trauma, media pressure, genetics, and finally, the fact that society strongly promotes thinness as the ideal body type.
All right, let's start with our first major disorder, anorexia nervosa.
Anorexia nervosa is defined by three core features. One, restriction of food intake leading to significantly low body weight. Two, intense fear of gaining weight even when underweight. And finally, distorted body image, where patients perceive themselves as overweight despite being thin. And here's the key point. Anorexia nervosa is not loss of appetite. Patients are hungry, but anxiety overrides their drive to eat.
Wow, so they want to eat, but they're afraid to, so they start to restrict food intake then.
Yes, exactly. This is the restricting type, where patients severely limit food intake. But there's a second type, which is the binge purge type. This is where patients binge eat and then compensate by vomiting using laxatives, diuretics, or excessive exercise.
Wait, Eileen, how is this different from bulimia?
Remember, the key in anorexia, even with the binge purge type, is the low body mass index, with a BMI of 18 or less.
So, anorexia is usually seen in young girls.
Yes, anorexia nervosa most commonly occurs in adolescent females, usually between ages 14 and 18. About 90% of cases occur in females, but it could also occur in males.
This food restriction cannot be healthy.
Right. In fact, anorexia nervosa has the highest mortality rate out of all psychiatric illness. Death may occur from cardiac complications, electrolyte imbalance, or even suicide.
Wow, highest mortality of all psychiatric disorders sounds very scary.
It really is.
How is the disorder related to the dopamine idea that we mentioned at the beginning?
Normally, dopamine release makes food pleasurable.
Right.
But in anorexia nervosa, dopamine release causes anxiety instead of pleasure. This occurs due to abnormal dopamine receptor activity in the striatum and basal ganglia.
So the brain literally interprets food as a threat rather than a reward.
Exactly.
These patients stay in a state of starvation for a good while. How does this affect their organs?
It affects far more than weight. Starvation impacts nearly every organ system in the body.
Okay, wait, let's start with hormones. What happens there?
The body shifts into survival mode. Estrogen levels drop and cortisol levels rise, which can lead to amenorrhea and over time osteoporosis.
What about the heart? That's something people don't always think about.
The cardiovascular system is significantly affected. Patients can develop bradycardia and hypotension, and with prolonged starvation, there can even be loss of cardiac muscle.
Does this starvation affect the blood as well?
Yes, of course. Bone marrow activity can be suppressed, leading to anemia, leukopenia, and thrombocytopenia.
Well, are there physical signs you might notice on an exam?
Definitely. You can see dry skin, hair loss, and lanugo hair, along with generalized muscle wasting throughout the body.
And finally, what happens to the kidneys?
The kidneys are affected mainly through dehydration and electrolyte disturbances, which can impair renal function.
So, overall, starvation really affects almost every system. There's also another pretty dangerous complication after prolonged starvation that happens particularly with treatment, and that is refeeding syndrome. Can you tell us more about it?
Yes, during starvation, insulin levels are low. When feeding resumes, insulin suddenly increases. This causes phosphate, potassium, and magnesium to shift into cells. Blood levels of these electrolytes drop dangerously low. This can cause cardiac arrhythmias and death. So feeding must begin slowly and carefully.
So, what you're telling me is refeeding syndrome is basically electrolyte imbalance due to rapid feeding after prolonged starvation.
Exactly. And the hallmark feature of free feeding syndrome is hypophosphatemia.
So, it's really important not to rush and feed anorexia patients very rapidly, because that could quite literally kill them. We need to take it slow. But what exactly are our goals in management?
Treatment involves three major components. First is nutritional rehabilitation to restore weight. Then there's psychotherapy, especially cognitive behavioral therapy. And finally, you can give them medications when needed.
What kind of medications?
We have two drugs that could help. Olanzapine may help stimulate appetite, fluoxetine may help treat depression, but only after weight restoration. It's important to remember that recovery often takes years, and many patients even require hospitalization.
Now let's move to another pretty known eating disorder, bulimia nervosa.
Bulimia nervosa involves recurrent episodes of binge eating followed by behaviors to compensate, like vomiting, laxatives, or diuretic use, or excessive exercise. When we say binge eating, we refer to eating a large amount of food within a 2 hour period, more than most people would consume during a similar period of time. There's also the sense of loss of control.
Okay, how do these patients look different from anorexia patients?
Good question. The key difference is body weight. Bulimia patients usually have a normal or slightly increased body weight, while anorexia patients are always underweight.
What kind of hormonal changes are happening in the brain in bulimia patients?
Bulimia is strongly linked to low serotonin levels. Serotonin regulates mood, satiety, and impulse control. Low serotonin leads to increased cravings, especially for carbohydrates, which leads to binge eating.
The most common picture is someone inducing vomiting after binging, but all that vomiting can't be good for the body.
Yes, it's not good. Frequent vomiting causes dental enamel erosion and tooth decay, esophageal inflammation and rupture, and enlarged salivary glands. If they use their fingers to induce vomiting, they may have Russell's sign, which are the calluses or scars on the knuckles. There may also be some electrolyte abnormalities, especially hypokalemia. Hypokalemia can cause dangerous cardiac arrhythmias.
I'm guessing we also manage bulimia by therapy, like anorexia.
Yes, you're right. First line treatment is cognitive behavioral therapy, and you may use medications sometimes. Fluoxetine or Prozac is the only FDA approved medication. So, management is really a mixture of psychotherapy, medication, nutrition education, and maybe even hospitalization. But it's very important for you to remember that bupropion is contraindicated in bulimia.
Bupropion is an antidepressant. Why can't we use it in bulimia?
Bupropion increases seizure risk in bulimia patients. It lowers the seizure threshold, and since patients with eating disorders are malnourished and may have electrolyte abnormalities, that just makes them at even higher risk.
So far, we've talked about anorexia nervosa and bulimia nervosa. Both involve restriction, fear, or behaviors to compensate. But there's a third major eating disorder that's often misunderstood and honestly far more common than people realize, which is binge eating disorder. Aylin, could you tell me more about binge eating disorder?
Of course, Mariam. Binge eating disorder, or BED, is defined by recurrent episodes of binge eating without behaviors to compensate. And that last part is critical. Unlike bulimia, these patients do not purge, vomit, or compensate afterwards. The calories stay inside the body. This is why binge eating disorder is strongly associated with obesity and its complications. But the key to understanding BED is that the eating isn't driven by hunger, it's driven by emotion.
When we talked about bulimia, we defined binge eating as eating a large amount of food within a 2 hour period, more than most people would consume during a similar period of time, with a sense of loss of control. Is there more to it?
Yes, during binge episodes, they eat much faster than normal and continue eating even when they're physically full. They often eat alone because they feel ashamed of how much they're eating, and afterwards they feel intense guilt, disgust, or depression.
This really is a repetitive, emotional, and distressing cycle.
Definitely, it's a loss of control. Patients often describe feeling like they cannot stop themselves once the binge begins.
Are these binge episodes what we look for in a diagnosis?
Yes, diagnosis requires binge episodes with an average of 2 times per week for 6 months.
What triggers these binge episodes?
The triggers are primarily emotional triggers like sadness, anger, frustration, loneliness, guilt, and feelings of inadequacy. Food becomes a coping mechanism that provides temporary emotional relief. But that relief is short lived and it's quickly replaced by shame and regret.
Wow, so this creates a dark cycle. When they get emotional pain, they binge eat, but only get temporary relief. That is followed by guilt and more emotional pain, leading to binge eating again. How does this relate to the brain's reward system?
The nucleus accumbens, which is part of the brain's reward system, becomes highly activated. This region normally responds to dopamine release and drives motivated behaviors. When someone eats highly palatable food, especially foods rich in sugar and fat, dopamine is released. This temporarily reduces emotional distress. And also remember, the stress hormone like cortisol weakens the prefrontal cortex, which normally helps regulate impulses. When the prefrontal cortex is weakened during stress, emotional impulses override rational control. So the person focuses only on immediate relief and not on future consequences.
So, what you're telling me is stress literally shuts down the brain's ability to regulate itself.
Exactly. It's all about cortisol giving the limbic system control over the prefrontal cortex.
So, this is why emotional eaters often describe feeling out of control. Their survival brain is overriding their thinking brain, bringing them back to a very old coping mechanism eating.
Eating is one of the first survival behaviors we learn as infants. Food is associated with comfort, safety, and emotional relief. So when someone experiences emotional distress, the brain instinctively returns to this primitive coping mechanism, and eating becomes a way to soothe emotional pain.
So, binge eating isn't about weakness, it's about emotional survival.
Yes, many patients with binge eating disorders have underlying emotional trauma, grief, loss, or chronic low self esteem. Food becomes a way to escape emotional pain temporarily. But because the underlying emotional issue isn't resolved, the cycle continues.
So, binge eating is like an addiction.
Yes, in fact, they both involve dopamine driven reward pathways, both involve impaired prefrontal cortex control, and both involve compulsive behaviors despite negative consequences. In both cases, the brain becomes conditioned to seek immediate reward to relieve emotional distress.
These recurrent binge episodes must ultimately lead to obesity, then.
You're right. The most common complication of binge eating disorder is obesity, which then increases the risk of type 2 diabetes, hypertension, cardiovascular disease, and obstructive sleep apnea. These complications can significantly reduce quality of life and life expectancy in someone with binge eating disorder.
For treating these patients, we have to target that emotional dysregulation that they have.
Yes, psychotherapy, especially interpersonal therapy, is essential. It helps patients identify emotional triggers and develop healthier coping mechanisms because ultimately, binge eating is driven by emotional dysregulation, not just hunger.
Psychotherapy is an important part of treatment, but what are some medications that we can use?
One major pharmacological approach involves medications that reduce the reward and pleasure associated with eating. A key example is the combination drug Contrave, which contains bupropion and naltrexone. Bupropion is an antidepressant that increases dopamine and norepinephrine activity, helping regulate mood and reduce compulsive behaviors. Naltrexone is an opioid receptor antagonist. It blocks the endorphin mediated pleasure response from eating. So when a patient eats, their brain no longer gets the same reward signal. This weakens the addictive reinforcement cycle.
Okay, so we can use Contrave, which is bupropion plus naltrexone. Can we also target obesity?
We can actually. There are a bunch of drugs now that can help someone lose weight. So we're talking about GLP-1 receptor agonists, like semaglutide, also known as Ozempic. And there's also tirzepatide, known as Mounjaro.
These medications work by increasing satiety signals in the brain and slowing gastric emptying, which reduces hunger, cravings, and binge frequency. They also directly affect appetite regulation centers in the hypothalamus. What if the patients are very obese, beyond the capacity of the drugs we mentioned?
In severe cases, bariatric surgery such as sleeve gastrectomy may also be considered. This reduces the stomach capacity and alters hormonal signals involved in hunger and satiety.
Okay, Aylin, we're almost done with this episode, but let's quickly wrap everything up. Eating isn't just about survival, it's driven by the brain's reward system, where dopamine is released from the VTA to the nucleus accumbens, creating pleasure and reinforcement. But wait, Aylin, how does the prefrontal cortex play into this?
The prefrontal cortex normally regulates this behavior, helping with impulse control. But during stress, cortisol weakens the prefrontal cortex, allowing the emotional limbic system to take over, leading to impulsive behaviors like restriction or binge eating. Now, to see how much we've retained, let's do a quick question segment on each disorder.
All right, so which disorder is defined by restriction, fear of gaining weight, and distorted body image? Even when severely underweight, also patients are hungry, but anxiety overrides their drive to eat.
That's anorexia nervosa.
You're right. Tell me more.
It commonly affects adolescent females and has the highest mortality rate of all psychiatric disorders. The starvation affects every organ system, causing amenorrhea, bradycardia, anemia, osteoporosis, and muscle wasting.
You got it. And treatment focuses on psychotherapy like CBT and medications such as olanzapine for appetite and fluoxetine for mood. We should also restore weight, but feeding must be done slowly to prevent refeeding syndrome, especially hypophosphatemia.
Okay, the next eating disorder involves binge eating followed by behaviors to compensate, like vomiting or laxatives. But patients usually have normal body weight. It's strongly linked to low serotonin, which increases cravings and loss of impulse control.
That's bulimia nervosa.
Yes, can you tell me more?
Complications include dental erosions, hypokalemia, arrhythmias, and Russell's sign. First-line treatment is CBT, and fluoxetine is the only FDA-approved medication, while bupropion is contraindicated due to seizure risk.
And finally, the last disorder involves recurrent binge episodes without purging, driven by emotional distress rather than hunger. Patients feel loss of control during binge episodes, followed by a feeling of guilt. They often develop obesity and metabolic complications.
This must be binge eating disorder, and it happens because dopamine reinforces emotional eating while cortisol weakens prefrontal control, creating an addiction-like cycle where food becomes a coping mechanism for emotional pain.
And treatment includes psychotherapy to address emotional triggers, medications like Contrave to reduce reward signaling, GLP-1 agonists like Ozempic to reduce appetite, and finally, bariatric surgery in severe cases.
And that's a wrap on eating disorders.
Thank you all for listening.
Until next time.
Whoa.